Nowadays, of course, the vascular accesses represent one of the last edges in complex artery repair as well as in infrarenal endovascular repair. The calcium, of course, is one of the most concern for surgeon in dealing with this kind of pathology, because calcium limited definitely the possibility to choose the proper graft for each patient. So sometimes we need to a reduction of the sheet in terms of course in diameter to obtain a safe crossing of the iliac axis. This is of course a pity for us because we want to treat the patient at our best and we want to choose the proper graft for each vascular anatomy. The calcium, of course, could lead during the procedure, during the advancement of a large bore sheet, to a dissection or a perforation of the vessel with major concern for the patient. As a surgeon, one of the alternatives is a surgical conduit that need, of course, more time for the procedure, an increased risk of bleeding during this kind of adjunctive maneuver. And it's, of course, depending on the experience of each surgeon to perform this procedure. An alternative could be a standard PTA, but with a very high risk of perforation of the artery and the bleeding, or the endovascular conduit. That is a technique that in almost all the cases require the sacrifice of the internal iliac artery, that in a complex endovascular aortic repair with proximal extensive aortic coverage could lead to the increased risk of spinal cord ischemia. So personally, this is not the way to deal with this kind of problem. And sometimes the endoconduits doesn't allow to modify the compliance of the vessel. And despite a new lumen, we are not able to advance our sheet inside an endoconduit. This is a big issue because the calcium sometimes is a segmentary inside the artery, but in almost all the cases you have an extensive calcification in all the axis, and this can afflict definitely the compliance of the vessel, especially in tortuous anatomy. So despite a good lumen, you are not able to advance a sheet or a delivery system inside the artery due to this reduction of the compliance. We are dealing with a 75-year-old male patient that was previously treated in our institution in 2009 for a ruptured infrarenal abdominal aortic aneurysm with a surgical aorto-aortic bypass. Now the patient presents a recurrent 55 mm in maximum diameter pararenal aneurysm. So we need to treat this patient, and we select for this patient a 4 inner branch endograft to deal with this pathology. In terms of vascular access, the patient presented a very tight and calcified ostium of both common iliac artery that require, in our mind, an adjunctive therapy to deal with the patient and to be able to deliver the graft. Considering also the CT scan, the patient has a very diseased thoracic aorta and aortic arch that doesn't allow us an upper extremity cannulation of the 4 inner branches. We need so both common femoral artery access, and for this purpose, again, we need to treat both common iliac stenosis. The IVL catheter, thanks to the sonic wave and to the wall position of the balloon and the lumen of the artery, allow to make a fracture in the superficial area as well as in the deep area of the artery, modifying the elasticity of the artery and allow us to advance a delivery sheet or a sheet inside the artery and to manipulate and to rotate the sheet as we want, because this is another big issue. We need to manipulate and rotate our sheet and our graft inside the patient to obtain the best position in terms of delivery at the intended position just in front of the visceral vessels. The reason why in this specific patient the IVL is of course our gold standard therapy is because we need to modify the compliance of this coral reef at the level of both common iliac artery, and we want also to save two big lumbar arteries that arise from the aortic bifurcation. And if we cover, of course, all the infrarenal aorta with a graft, we sacrifice this vessel, increasing the risk of spinal cord ischemia for this patient. We started using IVL. Of course, for this patient, we selected the M5 Plus catheter, 8 mm in diameter, 60 mm in length, and we start from the right side. That is the one we need for the 24 French advancement of dry seal sheet. And we apply 5 cycles in the right iliac artery. After doing that, we move the same catheter on the contralateral side, the left one, and apply the last 5 cycles in the left side. Obtain, of course, a nice luminal gain of the bilateral common iliac stenosis. After that, we advance the sheet through the right iliac axis without any kind of difficulties. And a 24 French sheet is a 26 outer diameter. It's a quite big sheet. It's quite amazing to go through this stenosis without any kind of problem. After this vessel prep in both common iliac artery, we are able to advance from the right side our endograft. It's an off-the-shelf endograft, and to deliver the graft at the intended position. From the contralateral side, the left one, we advance a 16 French sheet with inside a 12 French deflectable sheet in order to cannulate all the inner branches and to bridging all our visceral vessel. We complete easily the procedure, and at the final control performed with the CO2 due to an impairment of the renal function of the patient, we are able to assess a very nice patency of all the visceral vessel, a nice aneurysm exclusion, and no kind of dissection, perforation, or complication at the level of both common iliac artery. Finally, of course, we perform a duplex scan of the common femoral artery, and we have a very nice pulse with a triphasic wave, considering also the fact we obtain a nice lumen gain inside of both vessels. Nowadays, I think that the IVL technology need to be added in all the surgeon armamentarium who dealing with endovascular complex aortic repair, because the vascular access represents probably one of the last limitation in applying this kind of innovative technology. And we need this new approach because it's safe, easy, quick, and in particular solve the big problem of calcium in both common and external iliac artery for our patient.